Hey guys.
Hey, Miss Silk.
So I realize there's probably a lot of people that couldn't come right now, but I don't know what else to do as far as giving you guys information. I have to give it to you somehow. So I'm going to go ahead and do what I normally would do in class, and then this will record and I'll post it for those people who couldn't come. So um, what we're going to do is we're going to pick up where we left off last time we started talking about the intestinal stuff. So let me pull up that PowerPoint.
Also, while you're loading that up, I think 7 o'clock is the ATI training too.
Okay, if someone has to leave to go to that, by all means. You know this
Okay,
is
I think
being
I'll.
you know this is being recorded, so it's fine.
So I might have to leave at 7 to do that.
That's okay. Okay, so I believe this is where we left off. I don't think we talked about appendicitis, so this is where I'm starting out at. Okay, so with appendicitis, I don't know if you guys know anyone who's had this before, but your appendix is this little finger-like thing that's hanging off of your cecum or your part of your intestines here. And it seems like it's kind of a useless thing because um, really stuff gets caught in it. And, if you look it up and read about it, there's conflicting things. Some people will say it has a little bit to do with your immune system and stuff, and then other people say it doesn't really have a purpose, so you could get rid of it if you had to. So the problem is that things do get stuck in here sometimes. So it's this real little thing that is kind of long and skinny, and stuff can get stuck in there. So what gets stuck in there would be sometimes food, sometimes like they call it like a fecalith. So, stool would get stuck in there. And then as things get stuck in there, um, it has nowhere to go and it ends up swelling and you can get infected there. So here, we'll keep going with this. So anyway, the problem is if stuff gets stuck in there, then it's going to get inflamed. It's going to get red. It's going to get occluded. Um, so you have this inflammatory process that starts, and you get all this pressure that's building up in there because nothing can move and go anywhere because it's all this stuff is blocking it. It's closed off. So eventually, you're going to get pus that starts to form in there. So once this gets obstructed, the appendix becomes ischemic. So then it could die off. You could get bacteria that starts to grow in there, and you could even get gangrene. So you can get super sick from an appendix, getting messed up like this. So sometimes when people have this happen, they have this really vague pain in their stomach that is kind of hard to describe. So they say epigastric or periumbilical. And it progresses to the right lower quadrant. And then once it's down there, it feels very sharp and discrete. And you can say, yes, it's right here. And you can point to it. So when it first starts, you don't really, it's hard to say like where your pain is. But then as it gets worse, then it'll definitely be right lower quad. So you do have a fever associated with this, nausea, vomiting, sometimes loss of appetite. And then there is rebound tenderness. So, you know how we talked about that before, when you push down in that area, when you let go, that's when you're having all of that excess pain, and that's rebound tenderness. So this is especially noted at McBurney's point. So that's definitely, indicative of appendicitis. So this is something that I want you to focus on. So sudden temporary relief of pain may indicate a rupture of the appendix. So let's say I have someone that comes in with appendicitis to my floor. I'm taking care of them and they're having all kinds of pain. I have them on IV fluids. Maybe they're going to surgery tomorrow. I give them pain medicine every so often, but, I'm kind of just watching them until they go to surgery. Well, then, maybe a couple hours later, they call out on the call late and you go in to see them and they're like, hey, I don't know what happened, but I feel great now. I don't have any pain. Well, that's a red flag. That's telling you that possibly this appendix ruptured and that you have all this huge mess of pus and things all inside the body now. So definitely that's something you'd want to watch out for. So to diagnose this, I'm sure you're going to look at their signs and symptoms, and you're probably going to try to rule out a couple of other things because some of the symptoms are kind of common. So like maybe you do a urinalysis to rule out a UTI. You might want to rule out that this person's pregnant if they're a female. Stuff like that. So you're going to look at the abdominal ultrasound or maybe do a CAT scan to see for sure that that's what this is. Okay, so our biggest concern then is rupture. So if this thing ruptures, and it can do this on its own sometimes, so this would be perforation and you would get peritonitis because all of these contents would go out into your peritoneal cavity and you would get really sick. So that's our biggest concern. So like if you ever see a question about, hey, what's the priority nursing diagnosis for someone with appendicitis, what would you guys say?
Like a nursing diagnosis about a bursting, maybe?
Well, what I want you to say is risk for infection.
Yeah.
That's your priority. So the other things that could happen here, of course, with the fever and all of that, you just look and feel really sick. And then I have here, patients with peritonitis are often found to be supine and motionless. So this means if my appendix did rupture, when you came into the room, I would be laying flat and I wouldn't be moving a whole lot. Eventually, at first, when it first happens, you feel better and you don't have pain, but then pain will come back with a vengeance and it'll be awful. So the incidence of perforated appendix is higher in the older adult population. So that's something that you would want to keep in mind. So older adults sometimes are more at risk for this because they kind of poo-poo their symptoms and they don't come in right away. They think maybe it's something else. So that would be something to remember. So basically what we do for treatment for someone like this, if we figure out they have appendicitis, we bring them into the hospital, we're going to keep them nothing by mouth. We're going to give them IV fluids, probably give them antibiotics just to make sure that they're not infected. Give them pain management because it's very painful. And then they're going to do surgery. So they're probably going to take this out laparoscopically if they can. If not, then it'll be open, but usually 9 times out of 10, they do laparoscopic. So if they have to convert to open, it's because they have an issue and they can't get to it or something. Now, if the appendix has ruptured, that would be another reason why they would have to convert to open, because then it's a bigger job. Not only are you getting the appendix out, but now you have to clean out the whole area and it's just a huge mess in there. So anyway, a couple of things to pay attention to at the bottom here. I said, do not apply heat to the abdomen. So like when this person first comes in with appendicitis, if they ask you if they can have a heating pad, oh, that's a big no-no, because the heat can actually cause this person to perforate. So you don't want to do that. You don't want to give them an enema either. So if they say, oh yeah, I haven't had a bowel movement in 7 days, but they have appendicitis, you don't want to, risk anything there because you can cause this to rupture by giving them an enema. After surgery, you're going to put them in a high Fowler's position. So that usually is where they're most comfortable. But yeah, so you'll see quite a few people like this in your time as a nurse. There's quite a few people who have problems with their appendix. And, my mom, she had hers out and she totally wasn't expecting it. She came into the hospital for something totally different and then this happened. So a lot of people get their appendix out. All right, so the next thing on here is talking about diverticular disease. So we need to get into that a little bit. So you need to be able to tell the difference between what diverticulosis and diverticulitis is. So first of all, I don't know if you remember when we talked in the oral and esophageal chapter, we talked about esophageal diverticulum. And so it would be like a little outpouching of the esophagus. And so when someone would eat something, it would go down, but it would get stuck in that little outpouching, and then maybe they would have to regurgitate it back up. So now picture same type of thing, but now it's in your intestines. So it's like this little herniation of the lining of your bowel, extends through a defect in the muscle layer, and these can occur anywhere in the small intestine or colon, but most often occur in the sigmoid colon. So anyone out there could have a diverticulum. So then we get to diverticulosis. So what this means is, hey, now I have multiple ones of these. So I have all these different diverticulum, and sometimes they can cause me problems. So maybe they get inflamed at times, or maybe I, don't take in enough fiber or whatever, and I start to feel a little funny, and I can't have a bowel movement now because of this. Um, that could be diverticulosis. Diverticulitis, the difference here. So diverticulosis, hey, I just have multiple of these little herniations down through my bowel, and it's going to make me be more apt to be constipated and stuff like that because I don't take enough fiber in. So when it gets worse, it's diverticulitis. So now food and bacteria are retained in those little outpouchings, and they produce infection, just like what we just talked about with appendicitis, same type of deal. So this can impede drainage and lead to perforation of the intestine or abscess formation. So anytime someone has diverticulitis, they have to be admitted. So like I could just be, anyone out there in the world and have a diverticulum or have diverticulosis. That's not going to be something that's going to admit me to the hospital. However, diverticulitis, yes, you would be admitted for this. So you have an active infection going on because all this stuff is stuck in those little sac-like herniations. Okay, so this kind of just explains why you have these diverticula. So I won't read through all that, but with your signs and symptoms. So with diverticulosis, you have bowel irregularity. So intervals of diarrhea, nausea or anorexia, bloating or abdominal distension. So, hey, maybe I don't take in enough fiber, so I feel like I'm really constipated most of the time, but then sometimes I also go through bouts where I have diarrhea, and then I have bloating and abdominal distension. So that is going to be diverticulosis. Diverticulitis, when you actually have an active infection going on, you're going to have a fever with it. You're going to have increased white blood cells. You're going to have acute left lower quadrant pain. You could have nausea and vomiting, abdominal distension, intestinal obstruction, or perforation even from this. So it's a big deal when you have this. So as far as diagnosis, you would figure this out with a colonoscopy. If you did a colonoscopy, you could see if they had diverticulosis. You could diagnose it that way. For the diverticulitis, you're probably going to do a CAT scan with contrast, and then that's going to show more closely what's going on in there. With treatment, like I said, you need a high fiber diet. The high fiber diet is going to help you have more regular bowel movements and stuff. You want to decrease your intake of fat and red meats, have stool softeners, so that you could go if you need to, if you're getting constipated. And then also increase your activity, because a lot of these people are very sedentary that have diverticulosis. So if you do more walking and more exercise, that's going to help you. And then here's some specific things for both of them here. So for diverticulitis, when you have that infection, if your symptoms aren't super bad, if they're just mild, then maybe they'll put you on an oral antibiotic. They could put you on a liquid diet and then progress you up from there to, solid foods, as your symptoms get better. But if you're really sick when you come in with this, if it's like kind of more extreme, They're going to put you on IV antibiotics. They're going to keep you nothing by mouth. They're probably going to put an NG tube in. They're going to give you lots of IV fluids. And they're going to assess for signs of bleeding because we're worried about peritonitis and stuff. And, of course, with your CAT scan and all that you get, you'll be able to see if they have an obstruction or an abscess or something like that going on. Okay, so then we get into inflammatory bowel disease. So this is where we talk about Crohn's and ulcerative colitis. Okay, so both of these are autoimmune disorders, and they are considered inflammatory bowel disease. Don't get this mixed up with IBS. IBS is irritable bowel syndrome. These are two different things, so don't get them mixed up. Make sure you keep that straight in your head. So autoimmune disease. So remember, with autoimmune things, you can have exacerbations and you can have remissions. So there'll be times where you feel really good, and then there'll be times where it'll act up and you'll feel really bad. So with these, things that play a role in the development of this would be things like, hey, maybe it's genetic. I got it passed down from someone in my family. Or it could be a little bit of stress related. It could be environmental, part of that. Could be a hormonal problem. Could even be partly from food intolerances. So risk factors for inflammatory bowel disease would be being female, eating large meals containing large amounts of fat, caffeine intake, alcohol intake, and also stress. So the first one of the two we're going to talk about is Crohn's. And I want you guys to make sure that you can tell the difference between Crohn's and ulcerative colitis, because they have a lot of similarities, but there's some differences too, and you need to be able to tell the difference. So with Crohn's disease, this is where you have inflammation occurring anywhere along the GI tract. So this could be anywhere from the mouth to the anus. So you have these patches of inflammation that can occur next to healthy bowel tissue. So most frequently, these affect the terminal ileum and the colon. So as you can see in these pictures, it's very patchy. So you can have like a part that is affected, and then you'll have a nice healthy part, and then a part that's effective, and then a nice healthy part. So it's kind of very patchy. Now, with Crohn's disease, you can have diarrhea, you can have bloody stools, you can have weight loss, and then this is something specific to Crohn's. You can have nutritional deficiencies. So this is where you have impaired absorption of vitamin B12. And then you can also have an intermittent fever with this. That would be when you have your exacerbation, of course. And then the entire thickness of the bowel wall is involved with Crohn's. Fistulas are not uncommon. You could have nausea, abdominal pain, and also flatulence. So like if you're looking at these signs and symptoms, the things that you should like pick out that are different, that are specific to Crohn's would be that the entire thickness of the bowel is involved, because that's different compared to ulcerative colitis. The nutritional deficiencies, that's different. So that would be something you would need to know as well. And then also some of the complications would be different. So like the fistulas are a little different. So like here's the specific complications for Crohn's. So you could have perirectal or intra-abdominal fistulas. And remember, a fistula is just like where you have two spaces in your body that are connected now that shouldn't be. So like you can have someone who has a vaginal anal fistula. So that means their vagina and their anus are connected by like a tunneling, and it shouldn't be like that.
That's very gross.
Yeah, definitely. And there's a bunch of weird, connections that you can have like that. Other things would be like rectal abscesses or fissures. And then perforation and peritonitis would be, a risk here. And then, like I said, those nutritional deficiencies are really key for Crohn's. So for treatment then, we want to encourage patients to eat small servings several times a day, increase their calories, proteins, and fluids. And then for medications, they're going to do anti-inflammatories like sulfasalazine and corticosteroids during an exacerbation. Now, like the sulfasalazine would be something they would do daily, but like a regular corticosteroid, like a prednisone or something, that would be just during an exacerbation. Um, let's see. Also, antimicrobials to prevent and treat infection if they currently have one. And then sometimes people are even on immunosuppressants. So this is going to decrease and suppress the immune response. And then biologics. Sometimes you'll see people with Crohn's on those. So anything that's a biologic, it's always going to end in MAB. So you'll see the names I have listed here. So those would be biologics. So someone with Crohn's could have surgery, but it's not going to fix their Crohn's disease. That'll always be there. So the surgery would only be for some of the complications, like if they had a perforation or a fistula or something that they needed to repair. Okay, so then with ulcerative colitis, this is inflammation and ulceration that most commonly occurs in the sigmoid colon and the rectum. So remember the other one, you had it patchy and it could be anywhere along your whole GI tract. Well, ulcerative colitis is more towards the end of your GI tract, so your sigmoid colon and your rectum. Okay, so signs and symptoms. You could have abdominal pain with this. You could have bloody diarrhea with this, which is the same as you could for Crohn's, right? Bloody diarrhea. But look at this. The number of stools increases with an exacerbation. So this person with ulcerative colitis could have 10, 20 stools a day for an acute exacerbation. So that would be awful. So when they have an exacerbation, they could have, symptoms like with a fever and anorexia and stuff like that. But this person tends to have anemia. So like your H&H would probably be a little bit on the low side. And they could still have like a little bit of a formed bowel movement, but most of the time not. It's usually going to be very minimal. Oh, I just lost my place. Sorry, hold on one second. Okay, so complications from ulcerative colitis, you could have a perforation and peritonitis just like you could for Crohn's. And then look at this, you're at increased risk for cancer after 10 years of having this. And this would also be with Crohn's as well. You would be at risk for cancer for that too. So definitely a big time complication. So with treatment, it's going to be treated pretty similarly to Crohn's. So again, eat small servings several times a day. But the medications, aminosalicylates and corticosteroids to decrease the inflammation when they're having an exacerbation. And then for this one, you could do surgery if medical management was not effective, or if you had a complication like a perforation or something. So a surgery for this would include like a total colectomy. So if you took out that part of their colon that was affected by this, then you could essentially like kind of help them with this procedure. So typically, I think when people have ulcerative colitis, that is a thought that they have, after so many years of dealing with it, that maybe they would go to the surgery to try and cut down their cancer risk. So you could see a lot of people with this, that have the total colectomy, that have an ileostomy and stuff. All right, so I put a little bit in here about management of an ileostomy, and I know you guys know a lot about that already. This is just a reminder of some things you should know. It's kind of common with this kind of stuff, so I just wanted to put it in here just to remind you. And how often to change the appliance and looking at the skin and the stoma and all of that. Okay, so the next stuff in here is about bowel obstruction. So when someone has a bowel obstruction, it's a huge deal. So this can happen a couple of different ways. So if it's a mechanical way, This means that, you know, you could have like a strangulated hernia or any of these things I have listed here, intussusception, volvulus, a tumor, or an adhesion. So this is something actually physically that happened to your bowel that you need to fix surgically. So that is something that you always need to check out. Every time you think someone has a bowel obstruction, you need to get some type of imaging to make sure it's not a mechanical obstruction, because you're not going to fix it any other way unless you take them to surgery. Now, the other two ways, neurogenic and vascular obstruction, those are some other, you know, ways that you could get a bowel obstruction that maybe you wouldn't need to go to surgery for that, but you know, you would treat it like with an NG tube. So here's a picture of some of those things. So when I said intussusception, this D right here is intussusception. So it's almost like telescoping of the bowel. So like part of the bowel goes in on itself like that. Then there's also like if you have a strangulated bowel, like your bowel like wraps around itself like this, and you know, you can't fix that unless you go into surgery to fix it. So these are just some examples of some things you might see in there. Okay, so with small bowel obstruction. So there is a small bowel obstruction and large bowel obstruction. So if you know that it's not a mechanical problem, what you're going to do all the time is you're going to put an NG tube in. And you're going to keep this person nothing by mouth for a little while until that gets better. So what happens is all of these intestinal contents, this fluid, this gas accumulates above where the obstruction is, and you get lots of abdominal distension, retention of fluid, and then as it gets more distended, you get all this pressure that causes a decrease in capillary and arterial pressure, and this causes edema, congestion, necrosis, and eventually it's going to rupture. So I don't know if you remember when we talked about like megacolon, that's kind of what this is really. So a bowel obstruction that doesn't get fixed is going to turn out to be like a megacolon. So the signs and symptoms that go along with this would be crampy pain. This person could possibly pass a little bit of stool with blood and mucus, but not much of anything. This person usually has vomiting, and it's extreme. So sometimes people will vomit to such an extreme that you'll see it be projectile, and it'll smell like feces. It's bad. This person's going to be really dehydrated. They're going to have metabolic alkalosis, abdominal distension, you know, drowsiness, all that kind of stuff. So if you are trying to get some kind of imaging to see what's going on, usually an abdominal x-ray will show you. And then if that didn't show you enough detail, you could go with a CT scan, and that'll give you enough information. So again, you want to confirm the diagnosis, figure out what's causing it, and then you can fix it. All right, so we're going to treat it with an NG tube, give IV fluids because of the dehydration. And then if that didn't work after a while, sometimes you do have to go to surgery. You know, if there's so much blockage going on in there, sometimes that's the only way they can fix it, is to get it out surgically. So with a large bowel obstruction, you get accumulation of contents, fluid, and gas proximal to the obstruction. So this is another big deal. So with this, symptoms are going to develop a little slower. So if I had to compare small and large bowel obstructions, small bowel obstructions tend to happen a little quickly, and large bowel happens more slower. So you're going to have constipation with this, but you're going to actually be able to pass a little bit of stool, and it's going to be like diarrhea or ribbon-like stools around the impaction. Blood loss in the stool, you could have that. Weakness, anorexia, crampy abdominal pain, abdominal distension. And then the vomiting isn't going to be as much as it would be with small bowel. It's a little bit more extreme with small bowel. And then look at this, you're going to have metabolic acidosis with this one and fluid and electrolyte problems. So again, you want to treat this with an NG tube. You're going to treat their electrolyte problems. And then if, you know, what you're doing doesn't work after so many days, then you're going to take them to surgery. All right, so the last part of this chapter kind of gets into a little bit about colorectal cancer. So tumors in the colon and rectum are really common. Colorectal cancer is the third leading cause of cancer death in men and women. So some risk factors for this would be, you know, the older you get, the more at risk you are for it. You could have a family history of colon cancer. If you have had a colonoscopy before and you had polyps, you know, usually they'll take off your polyps during your colonoscopy, but if you have had numerous polyps, you're more at risk for colorectal cancer. Cigarette smoking, high consumption of alcohol, obesity, all of that, you know, plays a part here. The biggest type of colorectal cancer is going to be adenocarcinoma. So your big, you know, signs and symptoms to say, hey, this person might have this would be, hey, they have a change in their bowel habits. So, you know, maybe they aren't going as much as they used to be, or maybe they're going more than they used to be. Whatever the change is, it's different than what they were doing before. You could be passing blood in your stool. You could have unexplained weight loss, anemia. You could have abdominal pain, cramping, all of this kind of stuff going along with this. So your treatment for a person like this is going to be based on the Duke's staging classification, or the TNM method. So TNM stands for tumor node metastasis. So if you ever get a chance, when you do end up going back to clinicals eventually, if you get to take care of someone who has had cancer, you can try and find this in the doctor's notes. The TNM system, like you might see with the T, you could see TX or TO, T1, T2, T3, T4. So TX means that the main tumor cannot be measured. TO means the main tumor cannot be found. T1, T2, T3, T4 just means that it's like this the size, I guess, of it. So like 1 would be the smallest and 4 would be the biggest. All right, so that's kind of one thing that you could look for. So that's kind of interesting, this classification system. So if you did find out that someone had this, you know, again, their treatment is going to be based on how bad this is. So if you found it early, then typically you could treat them and not have too much of an issue. But if you find it late, then treatment is going to be more palliative related. So if you look at this slide here, this is talking about that Duke's staging system. So again, if you find it early, if you are Duke's class A or B, then usually you could do surgery and you'd be good. But if you found it late, you're usually Duke's C or D, and then this means that they may have to do both surgery and chemotherapy. So it's a little bit more severe. So this talks about like if lymph nodes were involved or if it's metastatic, whatever, it talks about all of that in this chart here. Okay, so again, I already talked about this. So you know, the worst type of tumor would be something that you probably aren't going to fix, you know, by taking out or doing radiation or chemo. So you're probably just going to do palliation with this person. And then I have listed here some of the different types of surgeries that they might do to try and fix this kind of cancer. Okay, so if you know someone has colorectal cancer and they have to have surgery, usually it's nice to get them with an interstomal therapist because this person can help them understand what they need to know for having a ostomy. They can, get them hooked up with supplies. They can do lots of education with them. A lot of times the endostomal therapist themselves has an ostomy, so they're kind of a good resource to talk to about it. So anyway, that would be something good to do for an intervention beforehand. And then usually this person's going to be assigned a case manager because they are going to have a lot of treatment down the road, and this case manager can help manage that. And then, you probably are going to have to do some type of bowel prep or prophylactic antibiotics before surgery as well. Post-op care is going to include a nasogastric tube. So usually they're going to come back from surgery with one. They'll have an ostomy, so a colostomy, and some type of incision that you're going to have to take care of. So those are some of the things that you're going to have to worry about post-op. And the very last part of this chapter mentions some of these weird anorectal conditions. And I'm just going to quickly flip through this because I can tell you right now, you're not going to have a test question on this. So anorectal abscess just means that you have a collection of perianal pus due to an obstruction of the anal glands. So if someone had this, you'd be worried that they would get septic from it. So you would want to do what they call an incision and drainage of that to get some of that out. And then you would have to worry about doing special dressings and packing it and stuff to keep it clean. An anal fistula or fissure, remember we talked about what a fistula is. So it's abnormal tunneling leading from the anus or rectum to the skin, the vagina, or the buttocks. And again, it's a big time complication of Crohn's disease. So you would have to get surgery for that so they could fix that, because that's not supposed to be like that. And when they do surgery for that, usually there's wound packing involved that you have to do. And then fissures, those are just like little cracks in your skin on your anal canal. So they can be pretty painful, but usually you just treat them with conservative measures first. And then if it was really bad, they could do a sphincterotomy to repair the defect. And we mentioned hemorrhoids before. These are varicose veins of the anus. They can be internal or external. And usually bright red bleeding with bowel movements would be bad. You would want to know about that. And they can also cause pain and itching. So treatment, usually you're going to do, over-the-counter types things. And then if that wasn't working, they could go on to do procedures like, rubber band them or do a ligation or a laser treatment on it or something. And then anal rectal STDs, of course, that could be bad. And then we've got pilonidal cysts. So this is, you actually have like a little nest of hair in between your buttocks back here. And this becomes infected basically. So you get pain and swelling there, and you end up having to do an I&D to like open that up and fix that and do, packing and dressings from that. All right, so that's that stuff. Questions about any of that?
No, it's pretty straightforward to me.
Okay. Anyone else? Okay, so the next thing I'm going to get into is a little bit about the liver. So this is going to be the hepatic disorders PowerPoint. So this is the only other thing I'm going to go over tonight. And then Tuesday when we meet again, I'll go over the rest. There's like a little bit about cholecystitis and pancreatitis that I'll go over on Tuesday. So that's kind of my plan. See if I can get this up here. Okay, you guys can see that, I hope.
Yeah, I can see it.
Okay, perfect. All right, so with this PowerPoint, the first thing I do is I try and tell you a little bit about what the liver does. So it's very important to kind of get down the you know, what it does, because as we talk about these disorders, it makes more sense when you know what it should be doing, you know? So we get blood flow to the liver from two different sources. So we have a portal vein, and that carries blood from the stomach, the intestines, the pancreas, and the spleen. Um, and it carries blood away from the liver. It's venous, and it's rich in nutrients, and it's absorbed from the GI tract. Then we have another way that we get blood flow to the liver. This is the hepatic artery. So this provides oxygenated blood to the liver. And both of these two things, the portal vein and the hepatic artery, enter the liver via a common vessel and flow through the liver tissue. And then blood leaves the liver via the hepatic vein and empties into the inferior vena cava. So you'll see as we start talking about like cirrhosis and hepatitis, when you have those problems, it's usually a problem with blood flow because, you know, all of these areas inside the liver are so messed up with scarring and whatnot that you can't get blood flow through where it's supposed to go. Okay, so another couple little tidbits about the liver. So the liver can store a lot of blood, so 200 to 400 milliliters of blood. It produces about 600 to 1200 milliliters of bile every day. And then this is kind of cool. The liver can sustain 90% damage with loss of tissue and still remain functional. So that means you can be awful to your liver and make it be really damaged, but it still can have a little bit of function to it. And then just, you know, FYI, your liver is located in your right upper portion of your abdominal cavity, and it's underneath your diaphragm. It's a vascular organ, and it's protected by your rib cage. Okay, so some different causes of liver disorders. So you could get a liver disorder just from a virus, or you could get problems with your liver from being obese. You could get it from insulin resistance, and then also from exposure to toxic substances like alcohol. Okay, and here's where we start talking about some of the functions of the liver. So I'm going to name off like 8 different things that the liver does here. So the liver plays a part in glucose metabolism, ammonia conversion, protein metabolism, fat metabolism, vitamin and iron storage, bile formation, bilirubin excretion, and drug metabolism. So as you can see, it does quite a bit of things. So when you have a problem with it, it makes a big deal. Here's a little bit of a picture to kind of show you where everything's located at. So again, if you can imagine at the top here, this is your liver. This is the right upper side of your abdomen. And then out of that, you have this vessel. So this vessel is your common bile duct. And then underneath that, you have your gallbladder, and then you have your pancreas, and then your duodenum here. So that kind of shows you where all of that stuff is. So I kind of repeat myself on some of these slides, so I'll go kind of quicker through some of this. So you know how I said one of the functions is vitamin and iron storage? So the liver produces and stores vitamin A and D, and then vitamin B12 and iron are stored also in the liver. And then with drug metabolism, barbiturates and amphetamines and alcohol are metabolized by the liver as well. So if someone, has an issue with alcohol abuse, you can see why that's a big issue. And then we always talk about, things that are significant for older adults. So with older adults, if you actually did an autopsy on them and you took their liver out, you would see that it's decreased in size and it doesn't weigh as much anymore. So the blood flow to the liver for an older adult is not as much anymore. It's decreased. You have decreased metabolism of medications, so older adults hold on to things for longer. And they also have an atypical presentation of biliary disease. So when we talk about that on Tuesday, you'll see sometimes they don't look like the normal person who's coming in for a gallbladder problem. They might totally look different. Increased prevalence of gallstones. So a lot of times older adults are going to have more gallstones. And then more rapid progression of hepatitis C to infection. And then more severe complications of biliary tract disease. All right, so if we're going to assess someone who has issues with their liver, there's certain things that we want to focus on. So we're going to ask them about their health history to see if they've had any previous exposure to anyone with, any kind of hepatotoxic substances. Do they have a history of alcohol or drug use? What kind of medications do they take? Do they have any history of bleeding problems? Any history of liver, gallbladder, or jaundice problems? What's their drinking history like? Do they drink alcohol? Stuff like that. And then with physical assessment, there are certain things that you need to focus in on when you're thinking about the liver. So with their skin, their mucous membranes and sclera, you might see jaundice. So, and this can be like just slight yellow, or this could be like bright yellow, depending on how sick someone is. You could see edema with these persons. They're going to be more edematous, and then they're going to have petechiae, bruises, spider angiomas, and palmar erythema. So palmar erythema just means that on the palms of your hands, they're going to be redder. And then you all know what bruises are, but let me show you, let me see if I can find a picture to show you. Let me stop sharing this just a second, of a spider angioma so you know what I'm talking about. Okay, so spider angiomas kind of look a little bit like this. So it kind of looks like a spider shape with all these little branches coming off of like something in the middle. So these can be in multiple different areas, but that's kind of what I'm talking about. Okay. Also, with the physical assessment, so those are specific to the skin. And then with male patients, you need to assess for gynecomastia and testicular atrophy, because they can have that. You need to assess their cognitive status because they can be confused. They can have tremors, they can have Arysterix, weakness, and slurred speech. And I'll tell you more about Arysterix here shortly because there's a specific slide on it, so don't worry about that just yet. But definitely their cognitive status is a big deal. You need to really do a good mental status exam there. Assess for the presence of abdominal fluid, because usually someone with liver problems is going to have a little bit of ascites going on. And then also, can you palpate the liver? And is it tender feeling to them? For diagnostic tests, you would want to do liver function tests. And some of the liver function tests that you would be focusing on would be your AST, your ALT, your ALP, bilirubin, albumin, and I think there's another one that I don't have listed on my paper here. I can't think of the name of it at the moment, but there's quite a few different tests that are involved with liver function tests. So it's not just one thing you're looking at multiple things. Also, you could do an ultrasound that's going to detect abscesses, cysts, tumors, or possible cirrhosis. And then, of course, we talked about liver biopsy before. So with a liver biopsy, this person would be nothing by mouth 6 hours before the procedure. You would have to do blood work beforehand to see what their coag levels are. So those need to be decent before they would do the procedure. So typically they want your INR to be about 1.5 or so. They don't want you to be like at risk for bleeding, basically, because then they're really going to have a hard time stopping it, after this procedure. All right, so I'm going to tell you a little bit about how they do this. So before they put the needle in to, get a little piece of the liver, what they do is they tell the patient to exhale completely and hold their breath. This is going to immobilize the chest, and it'll decrease the risk of penetration of the diaphragm with a needle. So, of course, they just put the needle in there, through the ribs, and they take a little piece of the liver and it goes into the syringe, and then they send it off for testing. So afterwards, you're going to put a little bit of a dressing on that, and then this person is going to lay on that side. Remember, they're going to lay on their right side, and they have to be on bed rest for 12 to 14 hours afterwards. And the whole reason for laying on the right side, we want them to lay on their right side for 2 hours afterwards. And this is going to help apply pressure so that you don't have all of that bleeding, because they're at risk for bleeding. And then complications you would want to assess for afterwards would be pneumothorax and also hemorrhage. So those would be your two big things you'd be worried about. All right, this gets into a little bit more about jaundice, but I'm not going to go into all this detail. There's nothing on the test that is going to ask you about all this. This is just an FYI slide just to tell you that people can have liver issues and still be healthy. There are certain conditions that people can have where their liver enzymes are going to be off, but they're still okay and you don't have to do anything about it. One of those things is Gilbert syndrome. This person it's because they inherit this trait from one of their parents. So they get this trait and that's what gives them Gilbert syndrome. So it's a harmless liver condition in which the liver does not properly process bilirubin. So there's no treatment required for it. Only if they start to develop jaundice or do something like that, then you would have to go do some type of treatment. But this person usually is going to be more at risk for gallstones in the future. So that's something that you have to watch out for. These other three things on the slide are also stuff that is passed down, hereditary, from your family. So they're all things that you don't have to do anything for, like as far as treatment. You just kind of watch and make sure they're okay. Okay, so this is an important slide. This is something that you need to pay attention to. So portal hypertension is something that someone with liver disease will have. So this means they have obstructive blood flow through the liver, and it results in increased pressure throughout the rest of the portal venous system. So again, just think about that last PowerPoint that we just talked about when we talked about bowel obstructions. If you have a blockage somewhere where you can't get contents through, you're going to have increased pressure, and it's going to cause problems to the rest of the system. So this is commonly associated with hepatic cirrhosis, and usually you'll see someone has an enlarged spleen if they have portal hypertension, and usually they're also going to have ascites and esophageal varices. Now, because you have this obstructed blood flow through the liver because of all of the scarring and stuff that's going on in the liver from their cirrhosis, blood tries to find a way to get around this blockage. So that's kind of how esophageal varices happen. So it's like collateral circulation. It just starts to form so blood can go to where it's trying to go to. So it like bypasses this area of blockage. And unfortunately, the esophageal varices, they're not really something that you want to see because they're very weak and they can burst really easily and cause, a bleed. Here's an example of someone who has ascites. So again, this is just fluid in your peritoneal cavity due to portal hypertension. So again, because this fluid is, you don't have this good blood flow through your liver, everything is backed up. So that's what's causing this person to have all this fluid buildup in here. So anyway, this changes the ability to metabolize aldosterone and decreases synthesis of albumin and movement of albumin into the peritoneal cavity. So this means that the fluid that's in this person's belly is rich in albumin. It has lots of protein in it. This is just a chart that shows you kind of like what happens step by step in ascites, but you guys can read through that on your own. So something you need to remember when you are assessing someone with ascites, you should be recording their abdominal girth every day. So this means that you would use like a tape measure and measure at a certain spot every day just to see if that has gone up or down. And that is going to help you monitor their fluid balance. Now, this person probably will have striae on their abdomen, distended veins, and maybe even an umbilical hernia. You should assess for fluid in that abdominal cavity by percussion for shifting dullness or by fluid wave, which is stupid. I've never seen anyone do this, but our book mentions it, so I had to put it here. I have another slide and I'll talk about that here in a second. And then also you want to monitor for potential fluid and electrolyte imbalances, because remember, when you have ascites, this is fluid in a place where it's not normally supposed to be. And so if that's happening, then that probably means that you have fluid and electrolyte imbalances too, because you're having all of this third spacing here. All right, this is that fluid wave thing I was trying to tell you. This is so stupid. So basically, like you would be this person that has your hand in the middle of this person's abdomen, and then you have to have a buddy come in with you to like hold on to the outside of their abdomen here. You would, according to this, the examiner places their hands along the sides of the flanks and then strikes one flank sharply, and you would be able to detect the fluid wave with the other hand. So an assistant's hand is placed ulnar side down along the patient's midline to prevent the fluid wave from being transmitted through the tissues of the abdominal wall. So essentially, I guess you'd be able to see the fluid moving under the skin and you'd be able to feel it as you're doing that, which is, what's the point? Okay, so treatment of ascites. So this is something that you definitely need to know. So first thing we're going to do is put them on a low sodium diet. That hopefully will help fix some of this. Next thing we're going to do is we're going to put them on diuretics. So typically, like a Lasix or something along those lines. Sometimes Lasix doesn't work for certain people, so maybe they move on to something else like Bumex or something maybe even beyond that. This person's going to be on bed rest. You may have to give them a paracentesis, so you may have to send them for, to get some of that fluid drawn off. Just imagine carrying all that fluid around with you all the time, how awful you would feel. You typically have a hard time breathing. You can't move around really well. It's just very uncomfortable for the person. So with a paracentesis, they take a ton of fluid off of you at one time to try and relieve some of that. And after they do that, think about it. If you took 2 or 3 liters off of someone, then what do you think their blood pressure is going to do? What do you guys think?
It would lower and drop, right?
Yeah. So you have to watch how much you actually take off. You can't take off like everything in their abdomen all at one time. You can take off quite a bit, but yeah, you can really drop their pressure. So many times after a paracentesis, they will actually put an order in for you to transfuse albumin through the IV to them. And that albumin is going to help their blood pressure stay up. And it helps replace some of that fluid that they have lost. Because even though that fluid doesn't belong there, where in their abdomen, there's still, it's like fluid that you should have had in your system, but it's just not in the right place. So if you're taking it out, they're still like, they still have a fluid imbalance. And that's part of the reason why they would have a low blood pressure. So remember, albumin is a colloid, and you don't have to give as much of it as you would a crystalloid. So typically it comes in a really small bag, and it works very well, and it helps with their blood pressure. Now, the next thing down here at the bottom talks about this TIPS procedure. So this is something that they would do down in interventional radiology. This is a guided imaging that is used to connect the portal vein to the hepatic vein in the liver. And they put a shunt in there, and it helps keep that open so that some of this fluid can drain better like it should. Now, you would think, oh, that sounds great. Why wouldn't they do that all the time? However, you can have problems from having this procedure, and it's a very expensive procedure and kind of risky. So, like, one of the problems you can have after this is you can get hepatic encephalopathy. And so you have to be really careful. So this is just done as a last resort with people. And like I said, it's very expensive. So you try everything else you can before you would go to that. This just talks about the paracentesis, which we already talked about. Okay, so that's kind of the background of some liver issues and things that you would see and do with someone when you're assessing them. So let's just think out loud a second before we get into hepatitis. And you guys talk, so it's not just me talking. So what are some of the big assessment findings that you would see in someone if they have a liver problem?
I mean, the obvious one would be jaundice, right?
Okay, what else? You guys can talk, it's fine. It's fine if you don't know, or if you think you might be wrong, just say something. It's fine.
Something with their eyes, maybe.
What about their eyes?
The whites of their eyes, maybe a different color.
Yeah, it could be jaundice.
Oh,
Could their urine be like really concentrated?
Yes, that's a good one. What would their stool look like?
Maybe like really smelly or dark.
No, it's actually going to be clay colored. It's going to be
Oh, okay.
light.
I was just guessing.
That's okay. And then remember that one slide I showed you, you can have lots of weird skin things going on. So you can have redness on your palms of your hands. You can have those spider angiomas. You can have swelling pretty much anywhere in your body. You could have ascites, like we talked about. So there's quite a bit of things you could see assessment-wise that would point to this, So just kind of be aware of those. Okay, so then we get into hepatitis. So there's kind of two extremes with the liver. So this is kind of not to say this isn't as bad, but it's maybe not as severe as cirrhosis. It's a little bit different. So hepatitis is just inflammation of your liver. So you can have a bunch of different types of hepatitis, right? And I totally wasn't even aware there were so many different kinds. It's crazy. So when you read about it, you'll see that there's a lot. But anyway, you can get this by a virus, which is the most common way to get it. You can get it by drugs or alcohol. So those would be some of the other reasons why you might get it. So like, someone who maybe has hepatitis B or C would be someone who probably got it that way. Maybe they had an infected needle or something like that that caused them to get it. So anyway, with hepatitis, what happens is you get all the scarring of your liver. And your liver actually, I think I have a slide that shows a liver that has this, or maybe it might be cirrhosis. But anyway, the blood flow through your liver, you remember how we said there's those vessels that go right through the liver, like in the middle, that carry blood flow? It really has a hard time getting through now because you have all of this swelling and all of this scarring and stuff that's going on. Okay, so I'm going to talk more specifically about some of these different types of hepatitis and things that you need to be like paying more attention to, not necessarily like, oh, here's how many days I can have it, like the incubation period and all that. It's more about how do you get it and how do you treat it and how could you prevent it? That's what I want you to be thinking of. All right, and then you also need to know that hepatitis can be acute or chronic. And chronic means that it lasts more than 6 months. So remember, acute is something that is going to go away. So like certain ones of these you'll see are just something that you'll have for a short period of time and then you get over it and then you don't have it anymore. So chronic would be more like your B and C. Okay, so hepatitis A is the first one we'll talk about. So this is one that you would get from a fecal oral route. So this means that maybe you had contaminated food or water, and that's what caused you to get this. And if you think about it, like sometimes people will go on vacation to Mexico or somewhere like that, and they'll get, really sick from some kind of contaminated food or water that they had. And usually it's going to be something like this. So again, if you're thinking, okay, well, how could I prevent this? Then you would want to make sure that you stay away from certain kinds of food and water. Maybe take your own bottled water with you or something like that. Or make sure that people are washing their hands really well before they handle food. That would be some preventative things. So for this one, this disease is not life-threatening. So that's why this is an acute form of hepatitis. So typically, this is just like you had gastroenteritis. So the symptoms that you would get would be just like that. You might have diarrhea, nausea, vomiting, that kind of stuff, and you feel awful from it, but it's something that you'll get better from, and it's not going to kill you, and it'll like run its course, and then you'll be all right. So this can be more severe in people who are older, of course. So, as we get older, we don't have as much of an immune system, so it can be a little bit more severe for those people. Let me tell you a teeny bit more about that before I go on to B. So another important thing to think about with these is what has a vaccine and what has an immunoglobulin. So hepatitis A does have a vaccine. And so if you knew you were going to go to Mexico or somewhere like that where they didn't have really good, food practices and stuff, then maybe you would want to get this. You get the vaccine, so hopefully you wouldn't get sick with this. It's a 2-step vaccine that you get. And usually it protects you really well. I actually had to get it when I went to Haiti years ago. So another thing with this, hepatitis A immunization is also recommended for post-exposure protection. So if you did get sick from this, maybe you get the vaccine afterwards and maybe it'll help keep your immune system, good so you don't get it again. There is what they call an immunoglobulin, and it's recommended for post-exposure protection as well. So there may be some people who maybe they're allergic to the vaccine, so they can't get it. So the immune globulin is not like a shot vaccine. It's like something that you take otherwise, which I'm not sure if it's a pill or what it is. It's probably like a pill, I'm assuming. So anyway, for this one, you would recommend this for people older than 40 and younger than 12 months. So anyone who's really old or really young who would be more at risk for getting sick, that's who you would want to have this. Also, anyone who has chronic liver disease, anyone who's immunosuppressed, or if they're allergic to the vaccine. So you could give them that immunoglobulin. Okay, so hepatitis B, of course, this is one that would be considered chronic. So this is spread via unprotected sex with an infected partner by sharing needles, accidental needle sticks, blood transfusions, hemodialysis, and you can even pass it from mother to baby, like maternal fetal route. This can live on dry surfaces for 7 days. And it's considered to be more infectious than HIV, which I thought was kind of interesting. I think people think the opposite. So, and it's kind of scary that it can live on surfaces for that long, huh? With this, you would get symptoms from this probably 25 to 180 days after you were exposed. So some of the symptoms that you might have with hepatitis would be very similar to what we just talked about with all the liver problems. So you could have anorexia, nausea, vomiting, fatigue, right upper quad pain, dark urine, light stool, joint pain, and jaundice. Okay, so hepatitis carriers can infect others even if they are without symptoms. They're contagious before and after the onset of symptoms, and some develop chronic carrier states. So you just may be a chronic carrier, so that would be bad. But anyway, this is like a really serious problem, this hepatitis B. So if you get infected with this, if you have an acute infection, usually they don't treat it. So they don't give you medications. They just do supportive care for your symptoms. And I wrote down here, if it's a newly acquired infection, individuals notice symptoms 1 to 4 months after exposure to the virus usually. Then if you keep a hold of this and it's still going after all of that time, if it turns into a chronic infection, then you want to give them antiviral meds. So antiviral meds would be anything that ends in a VIR. So adenofir, interferon alpha 2B, PEG interferon. And then there's like a couple of meds that you would see someone like with HIV take, like lamivudine. That would be one that's like an antiviral as well. So any of these you would want to give to someone that has this chronic hepatitis B. This may never go away completely, but you definitely, if you take medications, you can, live a longer life and fuller life if you take medications. So remember, there is a vaccine for this that we've all had, so the 3-step vaccine, so that would be a great way to prevent this. And then remember, to, be careful with some of your practices that you do to like help prevent this. With hepatitis C, you can get this by sharing needles, blood, sexual contact, You used to be able to get it through blood products, which you probably still could in some places, but most of the time not anymore. Organ transplants prior to 1992, needle stick injuries, tattoos, and also through cocaine use, which I thought was kind of interesting. Most
Uh,
individuals, yeah.
how through cocaine use? Like what? I don't get that.
Well, so think about people who snort cocaine. So it's contact with your mucous membranes, basically.
Oh, oh, okay. It's like okay, I get it.
Okay. All right. So with this one, sometimes people don't really have symptoms right away, so they could have it and still be a carrier and not realize. So it's kind of a big deal that way. Um, Hepatitis C is the leading indication for liver transplant in the United States. So usually if someone gets a liver transplant, it's probably because they have this. Now, this you could actually possibly cure. It's considered cured if the virus is not detected in your blood when measured with a blood test 3 months after treatment is completed. Unfortunately, there's no vaccine for that one. So there's no immunoglobulin for that one, no vaccine. Okay, hepatitis D. So this one is transmitted by parenteral routes. So this means like you get it through, um, you know, through like injections and stuff. So people who are at risk for this would be people with substance use disorders. Anyone with unprotected sex with an infected individual as well could get this. This usually when people have this, it's a co-infection with hepatitis B. So you would have two different types of hepatitis at the same time. As far as I'm aware, there is no vaccine for this one either. And then hepatitis E. This one is just like hepatitis A in a way. So this would be considered an acute infection. This is present in endemic areas where waterborne epidemics occur and in travelers to those areas. So it's fecal oral route, again, just like A is. And it's self-limiting, meaning that after you get sick from this, it won't stick with you forever. It'll eventually go away. So this one, you just do supportive care. There's no specific medications or treatments that you would give for this. Okay, the next couple of slides talk about the progression of hepatitis. No matter what type it is, you go through these different phases. And so there's 3 phases, and this is what we're talking about here. So pre-icteric phase. So this would be early on, so 1 to 21 days. So you may have anorexia, nausea, vomiting, right upper quadrant pain, weight loss, fever, malaise, maybe a little bit of arthritis. Your spleen would be swollen, and yeah, so that would be that phase. You could even, you could even have a low grade temp with that. The next phase is the icteric phase. So this would be 2 to 4 weeks. You would have jaundice, dark urine, pruritus, clay-colored stools, fatigue, and hepatomegaly with this. And hepatomegaly just means an enlarged liver. So the pruritus, remember that's just itching. That's due to an accumulation of bile salts beneath the skin. And the dark urine is caused by the increased excretion of bilirubin. So that's why you would have that. All right, and then the last phase, the post-icteric phase, this is when your jaundice disappears and you still have significant malaise and fatigue. This would be 2 to 4 months later. Your hepatomegaly would remain for several more weeks as well. All right, and then to diagnose hepatitis, you would look at liver function tests, But there's also specific blood tests for the specific types of hepatitis. So like if I'm testing for hepatitis B, I have a specific blood test that I do for that. So that's what this hepatitis serology is talking about. And then also you would look to see if their liver is enlarged with some, imaging of some sort. With diagnostic studies like with blood work, you might still want to look at their serum protein count. You would look at their bilirubin, whether it's in their blood or in their urine. You could do a liver biopsy. You could do a bilirubin and a ProTime as well. So really, when someone has hepatitis, there's not like a specific thing that you have to do for them. You treat their symptoms mainly, and especially if it's an acute form of the hepatitis. Most of the care can be managed at home, so usually you don't have to like admit someone for this. You really need them to rest their body quite a bit and receive lots of nutrients. So someone with chronic hepatitis, that's the one that you're going to give antiviral medicines to. These are taken for long periods of time and they have a lot of bad side effects. So not everyone responds really well to those. But the goal is if you have them on that stuff for quite a while, then you're trying to prevent their liver from failing altogether. I just told you all that stuff. And then with prevention, again, think good hand washing, safe water, pre-exposure prophylaxis, and then that's immunoglobulin is here as well. With hepatitis B, with prevention, you're thinking safe sex, you're thinking screening of blood and blood products, you're thinking immunization. And then with hepatitis B, they also have an immunoglobulin for that. So like if you were at work and you felt like you accidentally got exposed to someone's blood who had hepatitis B, they would put you on this and that would help you. So this should be given within 24 hours of exposure and then usually you're good. With hepatitis C, there's no vaccine for it. The CDC does not recommend antiviral agents for post-exposure prophylaxis. So just for preventative things, screening of blood, preventing needle sticks, safe sex, that kind of stuff. And then for other forms of hepatitis, remember we said you can get hepatitis a few other ways as well. So you can get it from drinking too much. You can get it as a hereditary disease. And then you could also get it from taking too much of certain medications like acetaminophen. So this is the leading cause of hepatitis when people take too much acetaminophen. So that's a big deal. I actually knew someone who did that and they got really messed up from it. Okay, also realize that if you have a fatty liver, if you ever hear that from your physician, that's a big deal. And that fatty liver could cause you to have problems with your liver in the future. So you would want to try and lose weight and keep good control of your blood sugar and all of that to make sure that it didn't end up turning into something worse. Okay, so then we get into cirrhosis. So remember, we just talked about hepatitis, and that's inflammation of the liver. So a little bit of swelling going on and some weird symptoms that you might have going along with it. But now with cirrhosis, it's taken a step further. So again, we were having trouble getting the blood flow through the liver to get the liver to do all of the jobs that it normally does. But now with cirrhosis, you have all the scarring, and it's like a little bit worse than just the swelling of the liver. So this can lead to necrosis and everything. So it can end up being really bad. Here's that picture I was going to tell you about. So this is a liver of someone who had cirrhosis. So when they took it out, you can see it's like very swollen. So it's enlarged and you see all those little black things all over it. That's the scarring. So blood flow had a really hard time getting through here. So with causes, like probably your number one cause of cirrhosis is going to be alcohol, but it's not always that. It could be from a virus. Like if you had hepatitis and didn't take care of it good enough, it could turn into cirrhosis. Also, if you had a fatty liver and you didn't really take care of yourself like you should, it could end up in this. And then also, as you'll see when we talk about some of those biliary things on Tuesday, if you have bad enough biliary disease, that could cause you to have problems with your liver as well. And then even the one at the bottom I thought was kind of crazy, but cardiac disease. You can have right-sided congestive heart failure and have liver problems. So things to watch for with liver disease. So if you are in early stages, you would just have slight symptoms. So, hey, I'm fatigued. I maybe have a change in my weight. I might have some GI symptoms like I don't have an appetite. I'm just really, fatigued and that kind of stuff. Itching of your skin, abdominal pain. But then as it gets worse, when you get, in the later stages, that's when you see the jaundice. That's when you see the petechiae, the red palms of your hands, all of the dependent edema and the spider angiomas and all of that. So you see they talk about this Aristorix here. This is called liver flap. So here's what that is. So if you were looking at someone who had cirrhosis and it was in the later stages, they would have this Aristorix. So it's a downward tremor of the hand on dorsiflexion of the wrist. So if I'm like flexing this person's wrist, they would just constantly do that. And of course, other things that would be associated with this cirrhosis would be ascites. And then, of course, your liver is going to be bigger. With assessment, and other things that maybe I haven't mentioned before would be this fetor hepaticus. This is a certain odor to their breath. Let me see on my thing what that says here. So it's either a fruity or musty odor that you smell in their breath, and that would be that. Other things that you could see associated with this, they could do a lot of vomiting. They could have amenorrhea, which means no period if they're a woman. Gynecomastia if it's a man. Testicular atrophy. Those neuro changes, how we talked about hepatic encephalopathy for a minute, and we'll talk about it more here in a second. And then that Aristorix. Those would be the big things that you would see mainly in someone who was more advanced in their cirrhosis. And of course, this talks about all the changes with the labs. All right, so to care for someone with this, you want them to get a lot of rest. You would give them certain B complex vitamins because they're not able to metabolize them anymore with their liver issue. Avoid alcohol, aspirin, acetaminophen, and NSAIDs because that's going to make their liver problems worse. And you would try to manage their ascites, like we said. So remember we said you would give them a low salt diet, maybe, do diuretics and stuff like that at first, and then possibly do a paracentesis. And then as this person's cirrhosis gets worse, you're going to start worrying about esophageal varices. Because remember we said that is where, hey, all of this blood is trying to get through the liver like it should, and it's coming up with a blockage because of all of this scarring in there. So blood eventually is going to try and get around this, and it's going to form these esophageal varices. And they're just vessels that form in the lower esophagus that are very weak, and they can break open real easily and cause bleeding. So some things that you might do to help treat cirrhosis would be give lactulose. Lactulose is a medicine that is something they would drink. It's a laxative, so it's going to make them poop, but it's because you are trying to get rid of all of this excess ammonia in their system because they're going to be high in ammonia. So anyway, the lactulose is going to bind with that and help get it out of the system. So that's what that's for. And then neomycin sulfate is another thing that sometimes you'll see people get. It's an antibiotic that reduces intestinal bacteria and decreases ammonia production in the bowel. Okay, so here's some interventions for excess fluid volume, which we already talked about. There also are some surgical interventions that you could do for someone like this, which we mentioned the TIPS procedure already, but there's some different types of shunts that they could do as well to help make this a little bit better. So this peritoneovenous shunt, this would be done after their second acute bleed. So if they had esophageal varices and they had this bleeding going on, they would try to do this. So this is not first-line therapy, and you could end up having complications from this, like thrombosis, infection, fluid overload, and DIC. Here's that TIPS procedure, and it talks more about that on here. And then, oh, I guess I don't have another. Anyway, there's a couple different types of shunting procedures they could do. I guess I didn't do another slide about that. So complications of cirrhosis would be hepatic encephalopathy, portal hypertension, and those bleeding esophageal varices. Those are the top three things you would see with problems with cirrhosis. So if you think about it with our care plan that we did with that scenario, that guy probably had cirrhosis, right? Or I think it even said that in the scenario. So, you know, you would have to think of ways to treat that to try and help him so he, you know, would be able to maintain some quality of life for a little bit longer. So with hepatic encephalopathy, let's talk about that a minute. So basically, this is the inability of the liver to detoxify ammonia. Ammonia is a byproduct of protein metabolism. So large amounts of ammonia remain in the systemic circulation and cross the blood-brain barrier, producing toxic neurologic effects. So with someone like this, they're going to be really confused. And this can range from anywhere from like slightly confused to all the way to lethargy and deep coma. So it can be a big problem. And plus they would have that Aristorix going along with this. So again, you would want to give them that lactulose to help get rid of that ammonia in their system to help with this. With the esophageal varices, again, they are just veins that form in your lower esophagus that are very weak, and they can break open really easily especially if you have high blood pressure, because all of that tortuous blood flow through there can cause that to break open. So this occurs in about 1/3 of patients with cirrhosis, and the first bleeding episode has a mortality of 30 to 50%. So you would really want to try and prevent this person from having this happen again, because they can go into shock and it could die easily from this. So people with cirrhosis should have screening endoscopies every 2 years just to, you know, watch these esophageal varices. So some of the treatment for these, obviously you would want to treat this person for shock if they were currently having a bleed. So you would give them blood products or IV fluids or whatever, you know, to help with this. You're going to put oxygen on them. They're probably going to need to have a central line. You probably give them blood products. But then other things that you could do, so some of the things mentioned here. So there's vasopressin or somatostatin, octreotide. Any of these medications would help decrease bleeding, so you may see those given. Nitroglycerin could be used in combination with vasopressin to reduce coronary vasoconstriction. And then also propranolol and Naldol to decrease portal pressure. These are used in combination with other treatments. So those are mainly just to keep their blood pressure under control so that you don't have this tortuous blood flow through those vessels that are really weak. This talks a little bit more about some of those meds. And then Iserdil even is used sometimes. This causes vasodilation to lower the pressure, and it's used with beta blockers. So other things to do, to manage these esophageal varices. So this person is going to be really scared when this is happening. So you want to try and use a calm, quiet approach and reassure them as much as you can. Teach and support the patient and family, and monitor these treatments that they're getting to make sure they're doing okay, and then give them frequent oral care, and then also monitor complications that they could have from their hepatic encephalopathy. Like they could go through DTs maybe even, because maybe they're, because they're such a drinker, maybe, maybe they're going to have these delirium tremens associated with this as well. All right, and then the last part of this, I think, just goes over some of these different things you could do for these varices. This is an endoscopic sclerotherapy. So you would do an endoscopy where they put this certain end on the endoscope, and you could inject these varices with a certain medicine to get them to like stop bleeding and shrink up. Then there's also esophageal banding that you could do through an endoscopy procedure. And there's also that balloon tamponade that we talked about before, so using that Synstaken Blakemore tube. With liver abscess, so if someone had a liver abscess, you would be worried about the liver being invaded with bacteria. So you would want to probably drain the abscess through ultrasound and then put them on antibiotics for that. If someone had liver trauma, like say they had some kind of accident and they had trauma to their liver, you would probably see abdominal tenderness, distension, guarding, and rigidity in their abdomen if that was the case, especially if it was like a gunshot or a stab type of a wound. And usually with this type of trauma, they're going to have to go to surgery to get this fixed. With cancer of the liver, this is one of the most common tumors in the world. It's also a common metastasis site for other cancers. So typically you see a cancer start somewhere else and then it metastasizes to the liver. Usually the most common complaint with this is upper abdominal discomfort. You'll probably see things like weight loss, anorexia, anemia, and weakness along with this too. With labs, you would probably see increased liver function tests. And remember we talked about a CEA before. This is like a tumor marker. So if you knew this person had cancer, you would monitor that every so often to see if your treatment was effective or not. And then treatment is going to include chemotherapy and maybe surgery. Surgery is a good choice if the cancer is confined to one lobe and the liver still kind of functions adequately. The liver can regenerate, so you could do like a lobectomy, or you could even do cryosurgery with this. And then this gets into a little bit about liver transplant. So this is used in the treatment of end-stage liver disease, and typically for like a primary malignant neoplasm of the liver. Like you would not do this for someone who has a messed up liver because they were drinking. That's totally, they would not qualify for a transplant. So with this, the donor program for liver started back in the 80s. Donors are usually cadavers. Recipients are strictly, on an online database, and they give the liver to the person who is the sickest and who is towards the top of the list. So as far as post-op, they're at high risk for 3 months for rejection or infection. In 6 to 12 months, they could return to normal activity. And of course, with any type of transplant, you're going to be on anti-rejection drugs for the rest of your life. So you need to make sure they understand that. And then with complications, some of the big things you'd worry about after liver transplant would be bleeding, hypertension, and infection. Those would be your big three. And then, of course, rejection if they had that. And then here's a picture of kind of the procedure of what they would do with liver transplant. There's quite a few incisions that they make, and you have different drains. And also you even have a T-tube drain here. So make sure you guys look at information about the T-tube. I'm pretty sure I have that on Canvas. And if I don't, I'll put it on there for you to look at. But you need to know how to take care of a T-tube. All right, so that's the rest of this. I'm not sure who's left with me. Who's in here with me? Anyway, if you have any questions, you know how to find me. Thanks for staying if you did.
You're welcome. Have a good night.